we're early. We're figuring this thing out.
But I always appreciate the technology. It's like, I don't want to have to do it, but I know there's something to it.
Well, we have so many good people that have so many different opinions. And if I can figure out how to organize it where everybody can say their piece and we don't talk over each other, then we're doing a good thing. You know?
I agree. So I only caught the last part of the last week.
Yeah, you didn't miss anything.
Okay. Where the audience coming from?
YouTube mainly. I'm using something called StreamYard to coordinate everything to put on YouTube to record where people can go in and ask questions, and then stuff from YouTube gets put onto StreamYard here, and then I'm the one that says, okay, let me put the question here, and everybody can see it and everybody can respond to it.
Okay. And
then I have disclaimers, check with your primary care. Here's Tony. Oh, hold on, Tony.
Is this your sister I've heard about, or?
No, this is Joy Lunt.
Oh, hi. Oh, we talked online.
Chicagoan, yes. How are you?
How cool. It's nice to meet the legend. But that's very cool that you're so willing to interact online. I do appreciate it. That's nice.
Well, my concern about interacting online is sometimes I come across as a grumpy old lady.
Oh, no.
And there are moments.
The same about myself. Sorry.
Are you telling me there's trolls on the internet? Come on now.
It's so true. It's so true.
Well, no, I appreciate you sharing the knowledge. Sorry, what was that?
I was going to ask Pete now. Mm-hmm. One of the things that I accidentally and naively got myself locked into here is Reddit.
Okay.
John Mekrut is a big Reddit person, and I don't get caught in the weeds on that, but I would love you all that's using it to put the link, like, will you click on to come in?
Because I think you'd get a ton of, because essentially that's what Reddit is. First of all, Reddit is a bunch of people asking horrifyingly general questions that would take 18 chapters to answer. And then people who don't know anything about anything are answering them.
Joy, I need you to put I put up the link 3 hours ago, and I think another one's going to come up in like 15 minutes that says, hey, we're going to do this live chat, come on in here.
Great.
So you and John can do that. Anybody else that's on Reddit, God bless. What I'm trying to work out with Tony here is we're going to have probably 6-7 people in the room, and I have to coordinate how the question is asked and then who's going to answer and all that stuff, because some people step forward, some people don't, and there's a lot of opinions in there. We're going to figure it out, Tony. I promise.
I have an idea.
Yeah, Pete, go.
Yeah.
Why don't you do it like when we see like the big news channels and they're interviewing 3 or 4 people? If Pete says, Joy, you want to take a crack at that one? And I'll go, Anthony might be a better one for that. I think some of us know each other.
Joy, you're natural. Let's do this show. And if you feel that coming up, I'm dead serious. Step forward.
Okay.
There's no egos here. We're just trying to get the information out there as easily and consumably as possible.
I found myself just sitting back last time because we have all these experts on, and I'm very new. So I don't mind listening in fact, I appreciate the knowledge. So, yeah.
Well, my thought, Tony, was you have that chat room with all those people in there. And now I know Joy's on Reddit. When you all hear what's going on, I sent an email, I do a Google search on news on mental health and neurofeedback, and I see what's popping up. And it's usually all the same stuff, and I share it with everybody. But if you all have something, new to offer before we get this thing going, I mean, please do. Hold on. Tony, what'd you put here? Reddit? Neurofeedback?
I put a link to, I don't know if that's Joy's group. It's just the top neurofeedback group on Reddit. If I search Google for neurofeedback and Reddit, that came up.
Look under private chat, Joy. See if that's it.
There might be 1 or 2 others. I can use their search to find more. Just in case you're looking to share it, I heard you. Yeah.
No, absolutely. In fact, last night I went through a couple of weeks worth of posts and took a bunch of the questions off of there.
Yeah.
Oh, wow. Okay. Cool.
No, Anthony, it didn't. So far, nothing. The thing it's called our Neurofeedback. Is the list that I tend to go to. Let me see if it's.
I think that's it that I sent. Yeah, it's the title of it is our Neurofeedback /Neurofeedback. I'll send. I can double check.
Look in the private chat, Joy. Do you see what he's got there? It's on the right-hand side. I don't know what screen you're looking at, but
let's see.
you click on private chat. You'll see Anthony Ramos, 5:40 p.m.
I have Anthony's thing, but not.
Hi, Joy.
Hello.
All right, we'll don't worry, don't sweat. We'll figure it out. What's on it before the show gets going? And
it says, "Is this live?" I see some chat over on the right-hand side there.
Is it live? Yes, it says it's live. Talabo, hey, Talabo, you got early access. You got Tony and Joy. You got any questions you want to ask to get it started? Because he's sneaking in.
Was that to us, Pete, the question? Or this is to the Talabo individual? Okay.
Talabo, he just said, hey, is it live? Yeah, technically it is.
We're breathing.
We're well, this is our second show, and we're putting things together here. And the only thing that keeps coming up is the elections, and depending on which side of the aisle you're on. Oh, here we go. Can you please talk about neurofeedback and autism? Go, Joy.
Well,
how many sessions till it gets fixed?
I have quite a number of years, and I don't know, many hundreds of clients who I've worked with autism. As you well know, autism is a spectrum disorder, so every single person is different. I have worked anywhere from very mild autism, sort of more Asperger's, all the way up to children who were unmanageable due to the level and completely nonverbal by the time they're 8 years old, stuff like that. I don't know how much we're going to get into this, but neurofeedback is life-changing for autism. I would tell you that maybe 5% of the autistic people I've worked with did not get life-changing improvements. They got some, but not that kind of stuff. We're talking about the very first young gentleman I worked with, 8 years old. I didn't know what I was doing really, but I said, let's try it. And 2 years later, well, through a series of notes that came from school, and mom and dad were both in the health profession field, and they were rather embarrassed at that point in time that they were doing neurofeedback because it wasn't well known or well accepted. So they didn't tell anybody. So the school was sending home notes every day going, who is this kid? Does he have a twin you sent to school? Because who's this kid, right? So their entire life changed. Their family lived around him. They didn't have to anymore. And by the time he got into middle school, obviously the districts are different, so all the paperwork changes. And the mother, we keep in touch. And so the mom came back to me and she says, they don't think he used to be autistic.
Wow.
Okay. Now, I will tell you, honestly, if that hadn't worked out so well, I probably would never have done another one. It was a challenge. And that's, of course, where you have to be careful how you pick your clinicians.
Yeah.
Somebody has to be patient and willing to work with your child because they will not sit still in a chair, obviously. They will not be wonderful, compliant people getting their EEGs done. You have to be very careful how you get the electrodes on their head. You have to be very patient with doing that. There's a world of difference. But when you're willing to meet them where they are, it's amazing.
Joy, what's your disclaimer?
Like just meaning.
I don't know. Tableau. What's his name? Hold on. Tableau.
Disclaimer.
Talalabo. He's asking us something. We're gonna talk about it, but you know what? Check with your primary care mental health professional.
Yes.
Right.
Joy's main autism research paper. So I didn't say this. Who said this?
That's Anthony.
Jay.
Jay. I'm sorry. That's Jay and Pineda wrote that paper, and that refers to their.
We should ask. I'm sorry, but we should ask both of them how many autistic kids have sat in their chair.
Yeah.
Sure.
All right. Hold on. Talabeo. Am I saying your name right? I deserve to be slapped in the face. I have a 5 years old with moderate to severe autism, nonverbal. Can neurofeedback help? And is 5 years old too young?
No.
Here, hold on. I think I figured this out. I think I did. How do I get this thing? There we go. See how this works?
Perfect. No, I've worked with kids that young and younger. I will give a little bit of a disclaimer here. When I work with children who are under the age of 6 or 7, I tend to be very, very careful in my protocol selections because their brains are still developing on their own. And I don't want to set it off on a pathway. All I want to do is put the train back on the track.
Mm-hmm. So
I tend to stay general. I do not use QEEG guided results for autism. I don't. You're gonna hear my QEEG. I worked with Jay. I was at Qmetrics. I've done the QEEG stuff. I know it, and I find it useful, but I don't use it to guide my protocols because there's just been too many times where something shows up as a finding. Oh, it's 3 standard deviations, too much. Well, let's put electrode there and inhibit it, right? What if it's the airbag that the brain created because the other thing on the left side of the hemisphere is irritating the living daylights out of it? You'll make the person worse. And when you do got QEEG guided, how will you know what to do? I talk to the people. They believe me, they tell me what to do. I know when I'm too low, too high, too wrong place. It becomes very obvious in their behavior, in their symptoms. So that guides me to go, oh, your brain didn't like that. And based on how it didn't like that, I know what to do differently. 5 years old is not too young. I will share a personal view of this. I think when we can work with kids this young, it saves them a whole lot of time of not having to live like that. So,
Joy, what's the intake that you do?
I do a clinical interview. It takes 2.5 hours to go through because I have so many questions that I go through. I am assessing for the arousal model. And then I go through each lobe of the brain has questions related to its function and the symptoms that show up. So I know, oh, if you have sensory integration problems, that's going to lead me to your parietal lobe because that's where that work happens. So I've had that. And if there is really something, if they've had a head injury, if they've had surgery, then I do a QEEG. So I do Q sometimes. I don't do them all the time. I warn people sometimes we might have to stop if you're not responding the way I am able to interpret, and we'll get a QEEG then, and we'll see if there's something in there that is different than what I thought. But so they aren't my first line of choice. When you ask the right questions, people can be very, very good at telling you what's wrong with their brain.
Do you think DNA helps with asking the right questions?
No.
So somebody's not susceptible to something from you fill out that questionnaire on the clipboard versus getting your analysis of the DNA. Wouldn't you rather take the DNA?
No, because nobody gets a clipboard in my office. They get grilled. I grill them.
Okay.
And if you haven't given me enough an answer, we don't go to the next question.
Do they even have a DNA test for autism at this time for clinical, or just curious? I don't know.
Well, okay, the DNA question. What would it help you know what to do?
Yeah, I hear you.
I mean,
well, we're talking phenotypes, right? So if something is gonna
Peter knows not where he steps, Anthony.
Yeah, that's
yeah. I'm
funny.
ahead of my skis. I know Dr. Marie and Jay's not here yet, so I can do whatever I want.
So Joy, I have observed people when they are treated based on their phenotype. I have seen side effects. It's not something I don't think it's very popular to talk about, and it's uncomfortable.
Yes.
Part of me wondered, and I do think perhaps some of these things are compensation. This is how the brain is coping somehow. But I do wonder, in an ideal world, could through other forms of treatment, maybe addressing somewhere else first, let's say, could you get a person closer to that kind of research associated ideal optimal brain functioning phenotype?
Okay. First of all, I think there has been some generalized misunderstanding about the phenotype.
Okay.
When you have a low frequency fast phenotype.
Okay.
Okay. It doesn't mean you're doing that all the time. It means we saw it for a section of your EEG and we went, that's interesting. We see that in a lot of EEGs, but it is not a constant factor. And so if you are telling the brain to do something about that, if that's not what it's doing, your brain's going to go, why would I do that? Okay. I mean, that the phenotype is, you don't have a phenotype. You could own all of them. That's totally humanly possible. We could look at your EEG and go, whoa, look at all of them.
Yeah.
Because from 1 minute to the next, you might have low frequency alpha. And the next thing you know, you have low frequency fast. And it's humanly possible to have a mixture of all of them. That's where the phenotype model started.
So on the spectrum of neurofeedback, and I'm using these terms because they sound so cool, you have autism over here and you have ADHD over here. ADHD is a lot easier to train than autism. Am I ahead of my skis there, Joy? Go.
Wow. That depends on who's sitting in the chair. I've had plenty of very challenging ADHD kids. Holy mackerel.
All right. 1,000 kids sitting in the chair. Make a judgment.
Right. Right. And, I've had, so one of the autistic kids, I was throwing my hands up in the air because I couldn't get the electrodes on his head and just have him leave him there for more than 10 seconds. He'd pull him back off again. So I looked at his mother and I said, is there anything, not perfection, anything that keeps his hands busy? She goes, well, we just recently got them all a guinea pig. I'm like, guinea pig? She goes, well, he's learned you can't squeeze him too hard because he'll bite him, and you can't let him go because he's hard to catch. So he figured it out how to sort of hold him. And I'm like, guinea pig, that's like a shoebox, right? Bring him in next session. And the next thing I know, I hand the guinea pig to the kid, and he's sitting in the chair, and our battle of electrodes begins. And he holds the guinea pig. He puts his butt under his chin and his head in his hands. It is the perfect posture for a neurofeedback session. He's not moving, and his hands are occupied. Bingo. But that's what we had to do to make that happen. Now, we didn't have to use a guinea pig forever. It was, 8 or 10 sessions, and then he was able to do that. But when you ask about how difficult it is to do, I'm not saying
difficult. I'm just saying to set the expectations for the parents, because they're all coming on. And look, everybody wants a fix. And the answer is it depends. Okay. Right. It depends. Okay. I get it. So, but what I have seen with ADHD is kids that sit in a chair and you get the electrodes, I shouldn't say sensors on the right way, and they're watching the Netflix, and their brain's doing what it should do, and they're like, whoa, wait a minute. They're sitting forward and staring at the screen when the kid was bouncing off the room. I dig that. I understand that. But autism takes way more training sessions than ADHD. That's all I was trying to say.
Well, okay, and I agree that's fair. Okay. But I will tell you that it is not that unusual for me to see major when we're dealing with really severe on the spectrum. It is not unusual for us to see enough of a change for the parents to go, what's happening? in about 10, 12 sessions.
Wow.
So are they done? No. But
Yeah.
something is happening that hasn't happened before.
I just wanted to share a meta study. This isn't phenotype. This is just a meta study by University of Cleveland, or I'm sorry, the Cleveland Medical Center, Cleveland. And they said one review of 30 studies on neurofeedback found a small to medium effect in mitigating ADHD, but a large superior effect in addressing autism spectrum disorder and a large positive effect against depression. So, it sounds like provider experience and skill probably matters too and things, but there's at least data saying that this is a good thing to look at.
Well, and one of the things that, I appreciate all of your sleuth work, Tony. It's great. But here's the problem.
Okay.
What are the criteria in saying it was a small to medium effect? What did it change and what did it not change enough to get your attention?
Mm-hmm.
Because I will tell you that when I work with parents, okay,
Mm-hmm.
part of my clinical interview is, what are the things that most need to change? I want to know what your expectations are, because then I'm going to set them right.
Okay.
I can't do a personality transplant, right? Sleep. Good one. And I like to use that one first, because that one's your nervous system. You can't control that with your thoughts or your mind. That is literally your nervous system responding to the work I'm asking it to do.
So how do you say that to the parents and they don't take it defensive? You know what I mean? They're taking it like I'm a bad parent. You know what I mean?
I'm a nurse.
Okay. Well, how do you do it? I'm not. I'm a video editor.
I have to talk to people a lot about stuff like that, whether it's, hospital side or this. First of all, when parents come in to see me, I usually haven't been their first line of treatment.
Yeah.
They've been to 7 or 8 or 10 or 12 different things ahead of me. And it is not unusual we did get something out of that therapy. We got a little something out of that therapy, and by the time they get to me, they're kind of like, well, we hope something. Right.
Yeah.
And, that's when I have to tell them, well, I will expect them, if they're not able to make eye contact, that's one of the things we're going to start to see. I will expect to see changes in their sleep. I will expect them to be able to fall asleep sooner and stay asleep longer. I try and set very realistic expectations, but I am also very fond of hope, because it shows up. I've watched the brain do some amazing stuff. I tell people, I am no longer surprised by anything that neurofeedback does, but I am amazed daily.
Cool.
But if you don't get the right amount of sleep and you fill the kids full of sugar, that doesn't do, right?
Well, it doesn't help. You're right. And so that's some of the stuff we have to talk about. One of the questions that I talk to them about is like, how does your child respond to sugar? Right? I'm not blaming them for giving them too much. I just want to know what happens. Because then when they bring him in and talk about, well, I'm like, didn't you say he was going to a birthday party last weekend? Okay. I'm not taking the blame for that one.
But blame is the key word. People get defensive, and then it slows down the progress, doesn't it, Joy? Because they don't want to clue you in on what's going on. It's like you're pointing the finger at them.
I don't. Oh, I never do that.
Yeah.
I never do that. No, it's never their fault. It's never. One of the things in my office is I have gone out of my way to make sure these children and these parents feel comfortable. They try and be on their best behavior. I'm like, don't bother with that here. Whatever. You want to knock a bookcase down? Go ahead. Whatever. I'm good with it. We're flexible.
Craig, am I putting your comments up, your questions here? I don't know which one you want. This is the first one, and here's the second one. Lots of difficulty with autistics, kiddos with
sensory processing disorder.
Yeah. And then there's the other one. And one more.
So one thing I will tell you, Craig, I'll go you one better on the electrodes. You send the old set of electrodes home, but not for the kid. You ask the parents to start wearing the electrodes around the house. So they become a common thing that the child sees. That's the first thing, right? And then you never approach an autistic child with an electrode trying to put it on his ear until you have said, let's put it on your finger. You go ahead and put it on your finger. And I use the ear clips. So the kid is willing to do that.
Mm-hmm.
And all of a sudden they find out, oh, it really doesn't hurt. They don't have to take my word for it. We've gotten over that.
Mm-hmm.
Yeah. The ones on the head, I'm sorry. Your technique has to be good enough that you're in and out. Boom. No playing with it.
Yeah.
So, but the electrodes going home has been a big help.
Mm-hmm.
KO says,
I can read it. I really appreciate having Joy's perspective. I think a lot of neuro approaches work, and I like to have those approaches represented.
well said, KO.
Yeah.
Thank you.
Joy, what was like has a child who's been treated and seemed to improve their symptoms from autism, have they ever said anything really meaningful or that made you feel good? I'm just curious, like some of those amazing things you've had said to you or.
Oh God.
Oh, hold on.
You're going to make me cry. Okay. Oh. Yes. There's everybody.
Hi there. Everybody at once.
Sorry, guys. I just look down and I say, oh, I see an eye patch.
We're all in the green room having crackers going, what the hell?
Oh, funny.
I am 3 minutes late. I'm so sorry. The talent is so demanding.
Man, I would object. They need better snacks, Jay.
Better snacks than crackers. I know. But Joy, I literally just walked in, so I'm thrilled you're here, and I was just overhearing some of the chat about working with autistic children and all the rest. Yeah, so hopefully you're holding forth on your vast clinical experience of that population, especially. Joy, in fairness, Joy and I know each other for a really long time, and she trained my daughter, who is on the spectrum.
Very cool.
And for those of you who may not know, Joy and I are co-authors on the phenotype paper, which everybody blames me. They don't blame her.
I know.
You show up at the eye patch, pal.
Yeah.
You're fair. You're obviously fair game.
We're also linked through good old Q metrics and all that other good stuff. The Q metrics and the QEEGs and the reports and all those wonderful things too. I've known Jay, and it's such. I got to tell you, this group is so lucky to have Jay. Jay literally is the world's expert on looking at an EEG. And until
there's your headline, EEG, Pete.
You cannot look at a QEEG.
That's not a headline. We all know that.
I know, but not everybody on the planet knows it yet. We know it.
You can't believe anything you hear. I pay everybody to say these nice things.
So. One of the things we're trying to do here is we got a lot of geniuses here, of which I'm not included, that we want to get people to ask questions and then let people respond. For instance, like Joshua, electrodes or sensors? What are your thoughts?
Oh, I call them sensors because it has a more accurate connotation to how we're using them. Maybe those same devices can be used, to conduct electricity, but we're watching, we're not reading, we're watching. And so sensors is more articulate. And when you say that to a small kid, it's like, okay, it's sensing, it's watching. And electrodes, they're going to make the wrong assumptions with that word. That's how I see it.
All right, Joy, here's what you got to do. If we don't hear from Joshua once every 15 minutes, we got to call on him. Fair enough?
Fair enough.
All right, Tony, go ahead. Jay, go ahead.
In the iSync Wave and iSync Brain group, they do connectivity analysis. And you can do sensor level connectivity, which is called coherence, or Granger causality connectivity at a sensor level. But you can also go to a source level. And connectivity at a source level is better information than which electrode is similar to another electrode. When you do source analysis and then do connectivity between sources, it ends up being better information. But they use sensor level and source level, so it gets away from electrodes there as well. So I think it's penetrated the neuroscience world fairly well to get away from just calling them electrodes. In EEG tech world, they still call them electrodes and not sensors, but they're they're not in clinical practice with autistic kids. They're in a hospital, and
Fair enough.
It's a totally different environment. So,
and riffing on the theme, is it training or treatment?
It depends on who you're talking to. And you know what, John? It depends on what letters you have after your name.
Yep.
Well, no, I don't dispute that an MD can call anything he'd like a treatment. I can't. I get that part. But
no,
what is it?
They have to show competence in the area that they're practicing in.
Fair enough.
The medical license is a general umbrella, but they still have to prove competence to the techniques. You can't, as an MD, go in and do brain surgery unless you've actually got
trained in brain surgery.
Yeah.
Okay, no, fair enough. But I mean,
hopefully,
conceptually, I favor strongly calling this a training. Yeah. I'm not doing neuromodulation. I'm not doing STIM. I'm not doing TACS, TDCS, any of that stuff. So from a neurotherapist point of perspective on the techniques that I use, I am very comfortable calling it a training. I really don't like calling it a treatment. I'm not doing something to them.
With clients that have epilepsy, if I'm working with them, I'm training them to optimize their brain. I'm not treating their epilepsy. The neurologist or epileptologist that they're working with is treating their epilepsy. And if we get them to the point where they don't have spikes in their EEG and the doctor sees a clean EEG, they don't want them on the medication any more than they want to be on a medication. So they'll cut down the med part way and see if the EEG stays clear. If it stays clear, they'll drop those meds. You might walk away from the diagnosis even.
Exactly. And hopefully in the extreme, avoiding surgery.
Well, I recommend surgery if you need it. I've had it. I needed it. It saved my life. But it also destroyed my pituitary, which is why I'm 20 plus years past the 50% survival rate after no pituitary. So, brain surgery is an important option. But for epilepsy, the first do no harm should be the thing in your mind. And you don't benefit from cutting something out that you could train. If you can't train it, at that point you may have to have it excised. But everybody used to think of epilepsy as a focus. It's this spot, but it's a network property. It's not a focus. So you can't cut out the network. And first thing to try is to train away the activity, and if it goes away with training, you've experienced neurofeedback as your success. And I've seen a lot of really impossible cases of epilepsy, intractable epilepsy, turned around to be seizure-free and medication-free. So if you can turn around epilepsy, you can turn around a lot of other things.
Exactly.
And autism is severe, but you can turn that around. If you can turn on autism, you can turn around less complicated things like simple ADD, if there's any such thing, or simple affective disorders, if there's any such thing. So if you prove it on the most difficult, it's easier to convince people that it works on the easy stuff. And
to this day, I don't understand why in most of our communities, there's still a resistance from neurologists. I mean, we have a few clients now where we've had incredible success reducing the amount of seizures, changing the type of seizures.
Oh no. Jay, what was she going to say?
It is a shame that it's not commonly.
Hold on. Here we go.
I give up. Thank you. Peter.
Hey,
It is a shame that it's not part of a common practice for epileptologists and neurologists. But you
there
have to
also
realize that
is some resistance because the clients report to their neurologists, "Hey, look what's happening," and we still have this resistance. I don't know how we can break through this because I mean it's long past the hearsay. It's a major issue in most of our communities. It really is.
Jay, you were there in UCLA in 2005, weren't you? The day of neurofeedback and QEEG at UCLA?
I was not. I was in Europe doing a workshop, and I was not there, but everybody else was there.
Yeah, and there was a moment.
There was.
I have it on DVD. If I can make a copy for you, I will. Mark Neuer stood up, and there was a sort of a group afterward, not afterwards, the end of it, and everybody's saying, well, what about this? What about that? And Mark Neuer stood up and said, Barry, because he was in the front row, why, if this works so well, why isn't it all over the place?
Yeah.
Why should I implement something that other people don't even do?
Yeah.
The question back at him was, why aren't you? Look at the evidence.
One of the most amazing things in all of history happened. Barry was speechless.
No, he was speechless when we gave him his Lifetime Achievement Award, and I grabbed the mic back from him immediately.
Oh.
But isn't there a moment in every new intervention that there's always one person who's doing it, and it just takes a while to percolate? The first heart transplant. You get down the list of things that happen that are breakthroughs in procedures. And, the intervention of neurofeedback in epileptology should be, but I think the answer is specious to say, well, why isn't everyone doing it? Well, because there are 6 people who are doing it with efficacy, and you're an idiot for not paying attention. What do you want me to tell you?
Yeah.
I'm sorry, you sound so angry, but it really annoys me, those kind of responses.
Yeah.
The field of EEG has been reduced to its least common denominator. You can see epilepsy and encephalopathies. That's it. Yeah. And it's good for so much more, and we know it because we see it and work in that area. But if you talk to a neurologist, their training has them ignoring classically identified patterns that are non-specific because they're not diagnostically specific. They could be epilepsy, they could be a psychiatric disturbance, but they've been classified as controversial rhythms or normal variants, and they're not. If you see somebody with a psychomotor variant, which is considered a normal variant, and put that person in front of a beginning psychology class, they would classify the person as not normal, as sick, not sick. Is this person okay or not? People will look at them. They're not street normal. It's easy to see that they're not okay. It's just that the pattern is not diagnostically specific. So as such, it's been dismissed. So all the color and flavor is gone from the field of EEG. So you wonder why they're not doing something with it. They've cut it down and down and down and down. And really, it's flourished, but not in the practice of neurology, in the practice of neuropsychology and biological psychiatry. Psychiatry is going through an identity crisis. If you go to the APA big meeting, it used to be 25,000 people. You couldn't hold it except for a couple of different big conference places. And, it's half of that size. Everything is shrinking. All the divisions are shrinking except biological psychiatry is exploding. Yeah. So, if the DSM doesn't have predictive validity, you can't tell me based on my DSM categorization what will work for me. What is the psychiatrist doing diagnosing you? It's a waste of freaking time, and ultimately they know it. They're searching for better method or a different method. So they grab onto the ICD codes. Well, that's just a different behavioral diagnostic categorization. It's the same mistake done with a different mechanism. Different
pharmacology still rules. I mean, we can say this all, that they're falling off of their pedestal, so to speak, but pharmacology still rules. Yeah, I don't know. I mean, it's just something I think it makes sense to bring up a lot. I've been watching some of the comments, and I believe with it, it's like one of the issues is our issue, which is there's non-standardization of practice. Again, in the community where I practice, we've got, track record of 20, 25 years, but we still, have supposed resistance. But again, how many individuals are out there calling themselves neurotherapists with, various levels of training, experience, and capability? So, yeah, maybe it is our fault.
A great example of what Jay was talking about. I used to sit next to the neurologist who came in to look at the EEGs for Q-metrics. And he would routinely look at these things and go, oh, slow waves of youth. So this is a particular pattern you see in the parietal lobes of people, okay? And I would look at him and go, that's a problem for the person. He goes, no, that's a normal variant until they're 25 years old. I'm like, so you're going to make this person who has extreme sensory processing disorder suffer until they're 25 years old before somebody looks at them and goes, that's kind of a mess, because then they don't know there's no medication for it. What does the neurologist do about that when they're 27 years old? Nothing, because by then they've made all kinds of compensatory weird behavioral changes. But you can look at the EEG and go, that's sensory integration disorder.
Yeah, and by then they're probably on some form of disability as well. Okay,
No,
folks.
but they are on drugs. They're on drugs. They're not on disability, trust me.
Okay.
Yeah.
Hey, well, we get a little break here. Anthony and John Mekrut, and thank you for Joy for showing up here. And of course, Dr. Marie and our guy Jay Gunkelman and Sky. Is Sky there?
Sky's here, but Renita's home, so he's occupied.
Right. Never mind.
John Hughes has a cheat sheet that doctors used to use, and on it has the posterior slow waves of youth, which is basically an immature thalamus. When you blend a couple of different frequencies together, you get phase addition. It looks like a sharp feature and then a big slow wave. And in his cheat sheet, it's a maximum in females at 5 to 6 years old. It's maximum in males at about 9 to 10 years old. It declines starting at age 10, and it's present in only about 15% of the people by age 16. So it's really not something you expect to see in healthy kids. After 12 to 15 years old, when you see it, it points to an immature thalamus. You shouldn't have an immature thalamus in your late teens, early 20s. They're giving it too much run, that they're not trying to call it. They're trying to avoid calling it. Like they try to avoid calling anything other than epilepsy and gross encephalopathies. And, that it's unfortunate. Mary Tracy studied in classical laboratories that did EEG and polysomnography, and she worked with the Navy's best doctors, and they thought that the EEG was an epiphenomenon, and it was good for epilepsy and encephalopathies, but the rest of it was just, it's an epiphenomenon. The real thing, you got to stick a needle in it down there and get a spike train, and then you can, brain surgery, you'd have to go in after it. Then you can trust it. Well, the first time she started to go over EEG with me, we're starting to talk about the neuropsychological presentation of the individual. This was a totally different world, and it got her interested in the EEG in a way that she had not been in decades. She goes back to the 70s, and like I do, but she was in a traditional laboratory and not not sitting at the end of a funnel with hundreds of EEGs a day flowing and trying to understand the patterns. I mean, that was in a unique circumstance, and just at the bottom of the right funnel to see too many EEGs.
Anthony, what was the study you're trying to bring up?
Oh, well, it was on the DSM a little earlier, and it's a psychiatry
Why would you
blog.
be there?
Yeah, right. Well, it was a psychiatry blog, and he's discrediting it. He says the title is DSM Disorders Disappear in Statistical Clustering of Psychiatric Symptoms. And specifically, it says that the diagnosis of major depression, in particular, completely disappears when you group disorders by their symptoms. And I've actually seen other studies of major depression. So you have psychiatrists that are even waking up. I think that's probably positive.
Yeah.
A headline today in the news, there's 6 different kinds of depression. When there's not really one, now it's 6, you know.
Why is it only 6?
Yeah.
Yeah.
Well, I mean, until they take that garbage out of the registration exams, we're still kind of stuck to it, because the schools, even though people are moving forward in practice, your gatekeepers, your initiation into practice, you have to really study and indoctrinate this, no pun intended. So, but I trust we're getting there. I mean, enough of us that are on the other side of the gate really, really feel strongly about this. So,
John Mekrut, can you read this next question, please?
Oh, God. Sure. This is from Kale. I'm not sure how to pronounce your name. Studies on neuro have small sample sizes, is complaint I've heard from skeptics and docs, and yet no standardization. There's not great research efficacy on some meds, and they're still prescribed, though.
Yeah.
Gee, I wonder why that is.
Yeah.
I cannot resist stepping in here with a.
Please.
It's not a small cynical attitude. It's a giant cynical attitude. Do you want to know what will make the doctors do this work? Get the insurance codes that they can bill for.
Mm-hmm.
I'm not kidding.
Yeah.
When did you last go see a doctor who works with the insurance industry who didn't make sure they had a diagnosis that fit and a procedure that fit with your diagnosis? We do not currently have any procedural codes that are refreshed after 1998. Nobody
Anthony, your thoughts from Florida?
Well, okay, so I'm going to be the bad guy for a second. I talked to an MD friend he's actually done neurofeedback. He's received treatment, and about the billing codes and about the standards of evidence. And he said, honestly, his suspicion is if it doesn't have billing codes, there may be an empirical standard that's not being met specifically. So as this is according to an MD friend, every approved medication in the US is subject to a sufficiently powered randomized controlled trial. And that means typically a larger size. And unfortunately, we don't have that. Now, in defense, this person references some of the medications have poor research efficacy. A lot of medications like antidepressants are being compared to placebo, and placebo alone in a lot of studies has 50% efficacy. So I agree that the medications are not all they're cracked up to be, but it sounds like there is probably something to be left to be desired with our research. And unfortunately, I don't know how to make that happen. So that's all.
If we had the billions of dollars available to us to recruit 12,000 people to be in a random controlled trial, which I find almost unimaginable, to be honest with you, I wouldn't know. I wouldn't know I'm performing neurofeedback on somebody. But putting aside the technicals, who the hell would pay for this? Only rich pharmaceutical companies can afford to launch that level of.
Hold on.
What Joy and Joshua? What are you putting up there?
Yes.
This is called biofeedback and neurofeedback evidence-based practice and it is done by the AAPB. This is the 4th edition of this, and it is basically divided into, I don't know. Let me look here. 42 different diagnosis categories that neurofeedback or biofeedback plays a role in. And in this book, they go through and they tell you what the level of efficacy for each one of these applications is. They cite the research, and they printed a number of the research articles in this book. It's 400 and some pages long. And it's like, and by the way, I have one of the first ones, and like what we didn't have efficacy in before, we do have efficacy now because more research has been done, more people have been taken care of. And so we do so too have that.
Well, we do, but Joy, in fairness, what Anthony's bringing up is a level of, if you're going to talk to a doctor who wants to see a study of 6,000 people, and by the way, let's critique those studies. Are they gender specific? How many women are being studied in medical research for medications?
Do we hold physical therapy to that standard?
We don't hold anybody to that standard. We do hold exactly.
Why are we looking to that?
It's a false paradigm.
When you have only small studies, the ability to actually do a meta-analysis exists. And that's what you do when you have lots of small studies. You do a meta-analysis, a study of the studies. And in epilepsy, for instance, the meta-analysis for neurofeedback shows 74% positive efficacy in intractable epilepsy. That's Gabriel Tan's study, meta-analysis, and there's been others as well that have done meta-analysis on epilepsy, but they're the percentage efficacy is higher than surgery, and it's higher than medication for epilepsy. In ADD, there's actually an ADD brief that can be handed to somebody who it's gone through the literature on ADD and talked about the clinical effects, how it's long lasting. It actually on follow-up has consolidated further. It doesn't degrade across time after you quit doing the training. It's a very, very positive review of the literature as a legal brief to be handed to the insurance companies by parent groups trying for parity. But it,
if I could just jump in here, I think the book that was held up, ISNR has a wonderful bibliography originally put together by Hammond, and also Cynthia Curson just did I think a year and a half ago, just did another one. It's there if we point people to, but the one that I keep on harping on is we don't have standardization of practitioners. So but we could go on and on about the DSM, we could go on and on about the prescription of meds, but they're prescribed by a very specific class of practitioner. And less BCI and the rest, but a BA is not an MA, is not a PhD, is not right. And so in terms of who is a neurotherapist and who are you going to and who is being reimbursed, there's still a lot of confusion about the practitioner, never mind the equipment and never mind the protocol. So I think we're really suffering from not just levels of organization, but levels of clarity to, amongst ourselves, to other professionals and to the general public. And I mean, I put a cry out for that a couple of years ago, and I'm going to keep on singing my song in that regard. How do insurance companies differentiate? Again, I'm speaking from Canada. We do have insurance providers that will support this and will pay for this, but it has to be done by a psychologist or a registered counselor. And of course, they'll pay a little bit less. They're not prepared to pay the price of a psychologist, but they will pay a standard rate. I think it's, I'm going to get this wrong, but it's anywhere between $165 and $200 an hour. And the going rate for a psychologist up here is $225. And I think it's just been bumped to $235. So, I mean, we're moving. But I think we have to structure ourselves better. Does anybody else think we're guilty in that regard, or is this my swan?
Mari, you and I have been down this road, perhaps gently, but we'll go a little more specifically. I don't think that necessarily psychologists should have the lock on who gets to do this. Why?
Tell me where in psychology school do they ever teach neurofeedback?
Well, they
Exactly.
don't.
No, start with that. But I mean, no. But wait. This is not psychology. We're not doing psychology services here.
Yeah.
That's not what
Yeah.
I do for a living.
Mhm,
I train brains, and I
Yeah.
train them well.
So-
And
we're
my
having the
lack of
wrong
a
argument.
psychology degree has little to do with how well I do it.
Yeah.
So that's
So,
the
I mean,
dividing
we-
line that I would
we-
argue that it shouldn't be
Yeah.
left just to that.
We
Can
100%
I
agree
We're
that
getting-
this is
we're
a
getting all-
complementary competence. This is a complementary competence. So after whatever degree, you have to learn this on top of it. Like, absolutely. But how do we clarify to the insurance companies who is qualified, why they're qualified, and what's the differentiation? John, I'm in 100% agreement. Somebody who is an MD, psychiatrist, or psychologist who's taken a 3-hour course and buys equipment is a very dangerous individual. At that point, I would trust somebody right out of high school, right? I mean, we're not going to argue about that.
How about a
the
licensure
answer.
for neurofeedback? How about a specific license for neurofeedback? Would
You
that
have to
solve the
get one
problem?
for every state, John. Who's going to take that on?
Okay, well, that's the only avenue that I
Wait,
can see
I
going
but
forward.
I have an
First one,
answer to
Joy.
Dr. Mari's question.
Yeah.
I cannot ask it for Canada. I absolutely can answer it for the United States.
Mhm.
Okay. Because for 8 years, I've been working with the AMA CPT code editorial panel, filling out the application to get these codes. And the answer to your question is in that application. When the psychiatrists went and asked for the same thing for their RTMS work, there's a box you have to fill out and says, who would be allowed to use this code? And their box says psychiatrists, not neurologists, not MDs, psychiatrists. Okay. We went entirely in the other direction and said, let's see. A physical therapist, an occupational therapist, a speech therapist, a nurse, a psychologist, a doctor, a dentist, because we have to cover for biofeedback and neurofeedback.
Right.
Okay. So we have tried to cover all the bases as to, and the answer to who is allowed to use this code answers the question of who will the insurance companies reimburse for it.
Got you.
There's a step-by-step process here. Okay. And to answer something Anthony might like to take back to his doctor friend,
Sure.
we were also asked to present research articles showing why it's a good thing. And we had to provide 2 that showed it was not a good thing. And everything that we presented, they said, that's fine. That'll get you in the door. So the AMA CPT code panel has approved the research that we've presented them with.
Nice.
That's great.
Congratulations.
Hey,
Excellent.
all, we're halfway through the show. Let's do an autopsy without blame. This is our second show doing this. And our people that are logged in, we got 7 people that are commenting. Thank you so much. How can we do this better the next time?
I think we've let several questions go by here that we haven't even touched.
What do you want to touch, Joy?
Well, Craig put some stuff up there about sensory integration stuff, and I will definitely step into that one. My experience is that sensory integration goes away with proper neurofeedback. Well, it doesn't matter if your daughter's 25 or 35 or 5. If your brain can get organized to do those functions, that goes away. And it's fascinating to watch it when it happens. People ask me all the time, like Pete did earlier, how do you know? What do you tell? And honestly, I tell people, well, when they walk in my door, they look comfortable in their own skin for the first time.
Yeah.
And I have an entire section of questions that I go through that analyze, because sensory integration is very complicated. It can be any of your senses, all of your senses, some of them too much, some of them too little. It's all possible. But the protocol is the same regardless of those things. So it becomes something that neurofeedback addresses magnificently. And the occupational therapy world is one of the only other groups that really deals with it. And I know that they've been doing it a lot longer than we have, but it's pretty amazing to see kids who were picky eaters and now they're willing to eat anything. They wouldn't wear the clothes with that. Now they're willing to wear anything. Adults who can't go into a restaurant because it might be different. it goes away.
Joy, who invited you? You are refreshing.
John
Mekrut? Speak up, John. Great call.
Yeah, I love this woman because on several levels, she helped my daughter immensely at a time when my family needed it. This is before I got into neurofeedback. You know, Joy is one of the people in a sense who prompted me to look at this as a potential career because I saw what was happening to my own child. And her perspectives on the simplicity ultimately of neurofeedback training to address a wide variety of issues, sensory processing disorder. What the hell does that mean? It means a bunch of things, and each person, not necessarily a child, each person you meet with this issue is going to present it somewhat differently. But the beauty of neurofeedback is it's a network-based, whole brain reorganization, training, uplift. And there's a million words for this. Peak performance training for the human brain. That's what it is. And it elevates every aspect of how you conduct yourself in this world. And I don't care if you've got AD, I don't care what your diagnosis is, ADD, autism, it doesn't matter. Yeah. The approaches are extremely similar to all of those things. And that's the beauty of it. That's the beauty of it. And there's no horrible
symptom based as opposed to diagnosis based, as opposed to label based. I mean, that's a real power. Yeah. And John, also speaking to, what you and I chatted about on multiple levels, I do have a critique about this, in some regards, but there's also, a huge, I would say, comment behind it. Why so many individuals with family members that have not found not even solutions, but even the vaguest hope or help in traditional methods are attracted to neurotherapy. I mean, there's a reason for this, and then they discover the power of it, right?
I was going to say, circling all the way back to why doesn't your doctor know about neurofeedback or tell you about it? Because A, they're not trained in school and it's not validated in their experience. Pfizer's paying a lot of money to put publications in their office on a daily basis about the advantages of Ritalin or whatever. That's what they are going to, that's what's in their face. We don't have that leverage.
It goes down the system too. I mean, how many teachers are telling parents you should put your kid on meds? If you really want to talk about quote unquote unqualified people. Yeah.
Oh, I have witnessed that in action. And I said to the person who said it, who was an assistant principal at a school, and I said, "Do you realize what just came out of your mouth? You could be charged for, and
but they never are.
To court and lose your house." That's a suable comment. You cannot make comments like that. You're not a doctor.
Yeah,
and
it's done all the time. Huh?
Regularly.
Hold on, guys. That's a great point. Who would like to take over the disclaimer? Go ahead, John.
We're not here to provide medical advice.
The disclaimer here is that we don't say those things to people.
Right. We don't.
Okay. Yeah. My licensure determines what I can say and what I cannot say to anybody who walks through my door. Okay.
Yep.
I'm a registered nurse. I don't get to talk about what vitamin D level you should be taking.
Yeah.
I can't even tell you how much vitamin C to take when you're sick with a cold. Okay. That's practicing medicine without a license. Now,
Joy, I have to giggle because so many times in terms of, my clients know me well, but I have my little diatribe. And before I say something, first, I have to qualify. I am not an MD. I'm not a psychiatrist. I do not have a license to dispense medication and I go through and they're like, yeah. I'm like, no, I have to say this. but it is interesting though, how sometimes, because of who we work with, the cocktails of medications they're on, and we see the effects on their brain. I think many of us are extremely informed. Disqualifier, qualifier. In fact, sometimes more informed than the individuals prescribing it, and that's a scary thing. And yet, I always have to do my disclaimer and refer the individual back, if not to the prescriber, then to somebody else who can, shall we say, check mark what I've shared with them. It's a sad state of affairs sometimes.
Mari, do you
Yeah.
know what your best bet is?
What?
I mean, again, this coming from a nurse. So I have many years of schooling and not speaking the wrong words and not saying the wrong thing in front of the wrong people. Nurses are like,
Yeah.
okay. So here's the deal. It's part of my intake. What medications are you on now?
Yeah.
What medications have you been on in the past?
Yeah.
Why did you stop taking them?
Yeah.
Okay. Because I want to know. It's huge to me in a neurofeedback sense. If I know what the chemistry did to you, I have some idea what the neurofeedback is going to do to you. Now, based on that, I suggest to them, I will ask them a couple questions. And if they don't know the answer, I'm like, you know what would be really worth your time? The next time you have a moment, go to your pharmacy and speak to your pharmacist. Your pharmacist is highly educated about all the medications you are taking. And when they come in and they have expressed to me that they would like to get off of their medications, we have different conversations about that. But I say, okay, here's what I want you to do then. I want you to go to the pharmacy and ask them for the full enclosure that they give about this medication. And I want you to take it home and read it and tape it to your refrigerator. Because when you start to notice side effects that you've never had before from that particular medication, I'm going to have you go back to your doctor and say, doctor, I'm having these side effects. And you know what the doctor does? Oh, then we should probably decrease your dose some. I don't have to confuse
or add a different one to take care of the side effects.
That's a too sad possibility. But my role that I take very seriously is teaching my people to how to be their own advocates with whoever's giving them medication.
Yeah. I mean, one of the best things that we had, now they're all over the city, but I would say around 15 years ago, the compounding pharmacists, to be able to have non-pharmaceutical dosages, that was just magnificent. And yes, we refer them to the pharmacist who gives them all kinds of ethical counsel in terms of what the dosages are and whether they should really be going up by 25 milligrams, et cetera. Yeah.
Well, Mari, thinking of that, there's a person with a question on ADHD medication. If I don't know, Talabo says, our doctor just told us last week to put my child on medication. She has both ASD and ADHD. I don't even know that. I don't believe there is medication for autism.
Yes.
Not traditionally. Is there any convulsant? I know Jay says. Go on, guys. Sorry.
No, I know what Jay's going to say.
Autism is a spectrum, and there isn't a medication for autism, but people will treat the attentional problem. People will treat the anxiety, but they'll give psychiatric medications in an attempt to help them. But the problem is that they go in based on the symptom of autism and not the EEG. Between 55 and 72% of the autistics have epileptiform discharges.
Bingo.
If you look at the entirety of everybody that was in all of the studies, it's 72%. If you look at each study's percentage and average it, it's 50 something. There was one study that had over 1,000 people. They did 24-hour EEGs, and they found 85% of the people that had autism had epileptiform discharges, but they looked at the 24 hours. If you have a very short study, you have a very small chance of catching one of these transients. So, even 55%, that's better than a flip of a coin. Half of your patients that walk through the door that have the ASD categorization, if you don't look at their EEG and you give them a stimulant or an antidepressant or any of the various meds that they think might be helpful, they may exacerbate the discharge. If you know it's there, you don't step in it. If you don't know it's there, you're up to your knees or deeper. And it's, not seeing it is because you're not looking for it. It's there. You just need to look. And, ADD, a third. So you don't have the 50-50 chance, but you've got enough of a chance that if you're not looking, you're going to step in it. If you're not looking at the EEG, you're practicing beneath the standard of practice you should be practicing at. because you're blind. In psychiatry and psychology, if you're not doing an EEG, what are you? I mean, it's the organ you're treating, but you're not testing it.
Yeah.
You know,
Exactly.
psychiatry. You know, why aren't you looking at their brain function?
The other thing is, I don't know about your communities, but in our community, the spectrum of ASD is getting longer and longer, wider and wider and wider. It's like it's the new catch-all for anything that we can't, put our finger on. Is that the same down in the US now, or where you're practicing?
Well, people are
Santiago,
arguing whether it's better diagnostics or if it's an actual increase in spectrum disorder. I would argue it's probably been there all along. Our perception of how to include people of divergent presentation has become more proper, frankly.
I agree with both of those, John. But I think the other component, I'm seeing a lot of things that previously were not considered spectrum behavior, mannerisms, or symptoms per se. Now, anything that's a little bit quote unquote atypical is being under that umbrella. That's really where my comment is.
And I think the danger, Mara, and I think you're on target here, is stop calling it a disorder. It's just spectrum humanity. That's it. That's it. People have different ways of perceiving and acting in this world. If it becomes, something that's interfering with their day-to-day existence or the existence of others, then perhaps something needs to be done about it. But we have to be tolerant of people who have different ways of being in this world. It's okay. Stop calling it a disorder. And again, neurofeedback, the central point of it is improve their function and all their behaviors are going to improve. What's the problem?
They may be on the epilepsy spectrum.
Exactly.
Well, right. But what Mari said earlier answers your question, Mari. When you talked about how, here we're looking at the DSM-5 now, right? For diagnosis causes stuff. What happens if you look at these people and you find out, well, yes, you do have this problem, but you also have the blending of diagnosis undercover shows up. Way more people show up on the spectrum. One thing I will tell you, I've seen over and over and over again 100 times. Every single person who comes in here presenting with on the autistic spectrum has some degree of sensory integration disorder. Okay. But I've also worked with many people who have really bad sensory integration disorder who are not the least bit autistic. And yet that is the diagnosis they've been given because they have this other thing. But nobody differentiates. So we have this ability to differentiate in such fine-tuning ways, that the diagnosis don't cover it. They just don't.
Don't matter. We're going to work on
except in the moment that we're living, it does matter because
no. I'm not saying it doesn't matter to the person, it only matters in terms of what we're going to do to assist them to overcome whatever that challenge is.
When they're in my office, yeah. But John, when I have a woman come into my office who is sobbing. And I'm like, are you okay? What's the matter? I just came from my psychiatrist's office. Well, he just told me I might have schizoaffective disorder. I'm like, what? Wait, what?
Yeah.
And immediately I'm like, what words did you say to her? What questions did she ask you? And literally tell me, what words did you say to her? Okay. And I gave her a bunch of Kleenex and she sobbingly, she said, I told her that I felt like I was in altered states. I'm like, well, that's why she said schizoaffective. I said, when you said that, what did you mean? It's a literal translation from Spanish, which it turns out, unbeknownst to me, is her native language. An altered state means I'm anxious and nervous. But her psychiatrist didn't know that.
Let's jump into culture of origin there as well, in terms of my gosh, the excessive, shall we say, interesting diagnosis of expressive Latino people. Yeah. This is just called a personality.
So I got the psychiatrist on the phone right away and I said, did you understand what she meant? Well, no. And I said, then I think she needs to tell you, and you need to tell her right now that that's not going to be her diagnosis. That's why it matters, John. That's why.
No. I appreciate that. It's what ownership we take of some doctor telling us we have something. We need to be.
On the other hand, though, especially with youth, I'm trying to see who's the youngest on the panel here. But they're yeah, it's not me anymore. It's really interesting how people are very, very attached and desirous of a psychiatric term now.
Yeah.
I mean, that's a really new twist. We've gone from complete disregard for mental health to the other extreme, where people are actually seeking and wanting and qualifying themselves by these diagnoses. It's kind of fascinating to watch.
Well,
this.
do we think does it give people comfort to at least have some phrase that describes how they're feeling? Does that give? That's my only conclusion, is that it gives them some comfort to have that.
I think yes, in some classifications. Sorry, Jay?
It gives them a name for what's wrong with them.
Yeah. It's almost like people want something wrong with it. There's a whole new classification out there, where individuals are there's a pride in it. There's a uniqueness to it. They want to have a diagnosis, and that's new over the past, I would say, 5 years or so.
I have to say that as I've looked over EEGs with clients and I've pointed at bad pathological findings, they've been happy to have it identified. They've been told it's all in your head. And now when we find something in their head, now they're happy that we actually found something there. But
there's a brain in there, yes.
They were being dismissed with it's all in your head. And the new term for that diagnostically is functional neurological disorder, which is it's all in your head classification without the pejorative to it. But it's commonly used to dismiss clients' concerns as it's all in your head. It's a functional neurological disorder.
Anybody want to take on dissociative disorder? I feel I've yapped a lot here.
Josh knows a lot.
No, just the increased popularity of it.
That I know a lot, Anthony?
Josh Moore, sorry.
Joshua.
Was it so obvious I was checking out?
What do you want to know, Marty?
That's funny. Well, no, I know you work with dissociation. Yeah.
Sorry?
Yeah.
No, I'm just speaking to how this is something that we're seeing more and more and more in, I would say, individuals from the age of 12 to 23.
The internet increases the amount of utilization of constructs for dissociative individuals. So you have people who are more dissociative who will use more constructs because the behavior is more modeled, whether it's on Reddit or on the media. But it's always existed, whether people want to accept that or not. It is true. I've got clients who are 80s who've had DID their whole life. It's a concept that when you raise your children, you notice that they have states and they can switch because that's just how they are when they're kids. And if you put kids under too much stress that they can't handle, they'll rely on these survival mechanisms far beyond what is developmentally appropriate, which is what DID looks like. And then the association is more than just the avoidance. It's the distance between some of these parts of ourselves that normal people who integrate with age don't experience. And they can be reintegrated quite easily.
But do we think that DID, dissociation is in a way a natural defense mechanism over to extreme stress? Doesn't it seem like
it's
fight?
It's an arrested development is what it is. So it's a coping skill that you have to have because you're a child's brain in an adult world, and you're faced with adult problems that you are not capable of handling.
Right.
Child solutions to adult
There's
problems.
Fight and flight. But if you can't escape, freeze. The feigning of death.
Right.
You know how they judge stress in a rat? How many shits there are in the cage? If you get to the point of fight, flight, freeze, there's a parasympathetic tone that kicks in, and it scares the shit out of you, literally. Yeah. So the fight, flight, freeze, that if you get to that end point, there's a dissociation that is the healthy way to get away from the perpetrator that's about to kill you or you can't get away from, that's sexually harassing you, or if you can't get away, the dissociation is the appropriate thing to do. Now, it's a state. Now, dissociative identity disorder is a different thing than being in the dissociative state. But the dissociation has been identified very nicely in fMRI studies. Thomas Ross out of Europe, and anyway, what they basically see is that the insula and amygdala end up being involved in this, and that's a limbic, and that's a part of the brain that's very primitive. It's not adult cortical overlay. This is limbic substructure, and if you've retreated to the limbic system substructure in a dissociation, you've turned off all of the adult resource, and it's difficult to come out of dissociative states, but neurofeedback can train people to control the network that's making that. And we work very well with people that have dissociation and PTSD that have been traumatized and somewhat occasionally ritualistically traumatized, and that almost a guarantee for dissociation at that point.
Yeah, absolutely.
You have biometric you can watch, and you can actually see when someone's dissociating. It's very useful. High heart rate variability, very, very low gastrostomic skin response. You'll identify that pattern as dissociation.
Yeah. I even wonder, piggybacking on what you were saying earlier, Josh, though, is, for some adolescents and youth, the loss of communication, or the loss of the development of communication skills due to excessive texting, that there could be that freeze point when they're put in situations, because they don't have the ability to face them and communicate properly. Yeah.
Absolutely.
Yeah.
Everybody, let me communicate to everybody how I think this is going down. And Jay, you and I, we've been doing this forever. Marie, Dr. Marie, you've hopped in. Anthony, Mekrut, John, and now Joy Lunt. I am very impressed with Joy.
You're welcome, Pete.
Thank you, John. No,
I told you, man. I told you she's a bomb thrower who's got a big brain, and with a big brain, it's a terrifying combination.
Here's how I think this is going down. I think we have different people. We probably have a dozen people at a time that are popping in, popping out, taking little views of this. And what I'm doing is, I have a chat where, like Craig Walker says, fantastic, love this format, and you folks, well done. Thank you, Craig. You are a smart man. So I have to watch.
He is our number one fan.
Well, no, we've got a lot of fans here, but I'm just letting you know how this works on this format, because I would love to have feedback how to get it better, because we want more people to come in. I don't know how we would do it with 100 people in here, but I would need. You can see what I'm saying is, on the right-hand side, you can see chat coming in, all of us, right? We have 7 of us in, and you can see on the right-hand side when people are asking a question. And I'm the one that's catching it now, and I think going forward, we're going to do more of it. Here, limit me to one question, Craig.
Yeah. Well, I think that's the point. I love the questions. Have we really had questions today? We've had a lot of comments.
Yeah. Well, I mean, Talabo's asked several really interesting questions. How many treatments do you recommend for toddlers? I'm 42. I'm not sure where that 42 number came from.
What I want people
That's
to
an interesting
understand is when people ask a question and then we don't respond to it, people get pissed off and they
No,
tune
exactly,
out.
and that's really hard. I'll respond right now. Talabo, my daughter is on the spectrum. And we started, with Joy and actually another person doing ILF. So in fairness, we explored around, and she's probably done in the hundreds of sessions, to be honest with you, about over 10 or 15 year period. We do some, we stop, we do some more, and every time she does, she gains and improves at her skills. Joy's work with her, I think, was really profound and got her off all her medications. If that's all that happened, I'd have been thrilled. It did far more than that. But with spectrum disorder, I think all of us here would probably agree this isn't a 20 session, 40 session in out. This is a long haul.
It's stochastic. Like, what's your start point? What are you coming in with? I mean, one of the things I love working with kids in the 7 to 9 year old range. They're in and out like revolving doors. They're old enough that that the ADHD or what have you is not just people having trouble adapting to natural children's behavior that can be, annoying or inattentive at times. So I don't like seeing 5-year-olds for ADHD because sometimes they're just children. But yeah, that 7 and 9, and of course, after 9 you get some of those freeze points in development, so it can be a little bit sticky. But yeah, what are we talking about? We're not talking about an age. We're talking about a condition or a symptom or a concern. Yeah, it really, really depends.
The other thing that's going on is maybe this is too early. Maybe it needs to be put out later. Jay, we've been doing this a long time. This is our second show. What do you think?
Well, I think that having a good sized panel gives us a broader range of opinions. I don't think that we'd be any less chaotic or more chaotic if we had 100 people versus 10 in the chat area. We'd still bounce around the same way we do because, all of us have opinions and need to have a chance to express them. But I think that the benefit here is that their questions can be answered by this group if they're a rational question, and they just need to pose it. If it's streamed past, post it again. We don't intend to skip any question. We're not question dodgers here. We're here to try and catch the questions and actually have a response.
Anthony and Joshua, your thoughts?
I think it's working. I have no complaints, and I don't mind people asking too many questions. We'll do the best we can. I wouldn't discourage anyone from asking.
All right, who's got the disclaimer then?
Joy,
go ahead.
Pete, okay. I have a request that might be completely irrational and impossible. I'm trying to keep my eye on the panel and everything's going on. And so I'm trying to look every once in a while over to the right side and look at the comments and stuff. Is there any way that a different color could be utilized if it was a question coming in from our audience as opposed to stuff that we're putting on there?
Only thing I know is, and Anthony, help me out, there's comments and then there's private chat. Those are the two. Private chat.
Well, there's also at the bottom of the screen the comments.
I'm just looking at that. I have the chat off. But
here, the bottom of the screen, just so everybody knows. Yeah. Look, there's no secrets here. We're trying to figure this thing out. Right. If somebody puts a comment in, all of us, the 7 people here, can say, I believe it's called show.
I see.
Right?
Yeah, Craig just put it up and Ron put it in. Yeah.
So every one of us can do that. And
I thought that was only you could do that.
No. We can all do it. That's
don't, Pete, don't let us have that power. Talk about chaos.
The problem is we have so many great minds here, and everybody wants to say something, and then we're all respectful. And okay, I'll be the one that's Jay, you got something to say. Tony, you got something to say. Dr. Marie, I'll be that guy. But going forward, we have more people are going to. We got 16 people. We've never had. Well, it's the second show.
Well, how about one of us read out the questions? That might be something.
Well, here I have a question actually, because not what I understand. Marie asked a question about how to convince somebody. Craig responded. Is Marie seeing his response in the chat? in the comments. Sorry, in the comments.
If you go on comments, all of us have the ability. Joy,
Marie as a commenter, is she seeing Craig's response comment?
She is on YouTube. On YouTube next to the video.
All right. I didn't. Yeah. So Maria's saying yes. I saw the response.
Oh,
Thank you, Maria. Thank you.
Thank you, Maria.
Maria.
Yeah, I wanted to address it as well, and I'm delighted Craig did, because he said exactly what I would say.
Wow.
We don't convince anybody to do anything. We're just sort of here's an option for you.
On the other hand, if you look at the long haul, like 25 years of medication versus 1 year of neuro, the math is actually in favor of neuro. It's just a matter of how big the payout is.
And the side effects and the negative consequences of various medications over time, loss of income, loss of stature, growth factors.
John, that's enough.
Insurance companies.
No, I'm sorry. I want to answer.
I love you, Joy. I love you.
Twice. The answer to Marley's question. Okay. I do this. I'm in semi-retirement now. I'm only working 5 days a week. For 30 years, I work 6 days a week. Okay. So I'm slowing down.
Yeah, we're bumping nuts.
I do this several times a week, maybe often on the phone. Okay. She asked, how do I talk somebody into signing up for more than 100 sessions? I don't. Okay.
Exactly.
So here's the deal. You come into my office. We discuss what your problems are. What are your struggles? What are your difficulties? I will not tell you how many sessions you need. I will tell you that, there's a lot of myth and fairy tales out there about 40 sessions. I think you need to go back and read where that originated. And it was with a very simple, uncomplicated case of ADD. And if that's what you're presenting with, probably 40 sessions is going to be about right. But if anything else comes in, I don't know. You're going to have to explain to me how fast you learn stuff. Okay.
Exactly.
But what I do tell them, because you know what the real question is, are you going to take me for a ride? Are you going to take my money and my time? Is this some kind of scam? Right? Yeah. Okay. Yeah. So what I explain to them is simple. Look, I keep track every single session. I ask you, how are you doing with this? How are you doing with that? We've talked about sleep. We've talked about different problems. We explore your symptoms. And I am keeping numerical data on every single one of your sessions. So I know what your brain has been doing. Now, I don't know what your perfect lineup of numbers is ever going to be, but I know which direction they need to go. So as long as they're going the direction, it's a trend. It's not a point by point graph. But what I want you to know is that I will not waste your time or your money. You and I are going to work together as a team to decide when you've had enough sessions. Because when you come in and tell me the things we talked about, they're all better. They're all resolved. And I'm looking at your numbers going, and your numbers have been steady good. Right. Now, our challenge is, can you maintain those numbers?
Maintain them. Right.
So I need to see you less often. I'm going to have you come in once a week for a month. And I want you to sit down here and tell me how your symptoms are this week and what your numbers look like. And if at the end of a month, your symptoms are good, your numbers are steady, we're going to say, now I need to see you 3 more times, once every other week, because I want to know if you can maintain this for 2 weeks without a session. Because my experience has been, if you can do that, we're done. Send me a Christmas card once in a while. Let me know how you're doing. Okay. So you have proven to yourself more than me how many sessions it took to get you to that point.
Yeah. I'm going to piggyback you, Joy.
No, I was going to say that's the only legitimate way to think about this for anybody listening who's considering wanting to try neurofeedback and thinking maybe it's a scam. This is about engaging with one of us as a professional to help guide you through a process that we have every expectation is going to advance your behavioral impact in the world, which is all this is about. It's not about the brain maps or the brain waves or any of that. That's all information for us to know, but it's about how do you operate in the world? Are you successful at fulfilling your life mission statement? That's what we're interested in. And until you can, and when you tell us, I feel confident doing that, you're done. I don't need to see you anymore.
Because you know what, John? If I come up and I show you a normal QEEG and you don't feel normal, how satisfied are you?
Exactly.
Bingo. Yeah.
Exactly.
No, I want to jump in also, in terms of like all of us here collect data. We know how to read data. And one of the things I'm sure everyone will agree with me, sometimes the objective data, whether we're doing numerical or looking at the waves, et cetera, move before the subjective, where the symptoms do, and sometimes the opposite. And if you're just very, very open and collecting, I always talk about triangulating. How are you feeling? What is the data saying? And what are the people around you saying they're observing? So I always triangulate. And then the other thing is, we're also talking about liabilities here. Not every abnormal, sorry, John, but not every atypical marker that we see has expressed itself. We're talking about liabilities sometimes as well. And I think my last comment on this one is we're done when it's good enough. And I like to separate that when you're good and it's enough. And if things start to return, and you need some booster sessions, you know where we are, right?
Quick question for Talabo on the chat. They asked rather. Not sure if this question was answered. Is 5 years old too young for neurofeedback?
No.
Younger the better.
Yeah, but it depends on what it's for. I mean, for some people, like if you have, any seizure activity, get in there immediately.
And there's some discussion for tactile feedback.
I like to press a little bit of a pause button, and really chat with parents or teachers or what have you of what childhood really looks like. And sometimes, for example, it can be the anxiety levels of the parent, not the child. So, yeah.
Josh, what is the tactile feedback you mentioned? Could you say that again?
I think Jay did the research, so I'll let Jay speak to it.
Sure.
Tactile feedback is essentially vibration. And when an infant is too young to focus on a cartoon on the television, even, how are you going to get feedback to them? And having them with a vibrating pillow or vibrating teddy bear is basically a way to get that done. And vibration is a positive sensation for kids. I mean, you don't want it too strong and too sudden. Like a slap, but a vibration is a positive sensation, and kids will do things to get their little buzz back. If they have the ability to create that buzz again, they're going to do it.
I want to step in as the nurse.
Yesterday on the
I want to step in as the nurse. Josh,
you said a pacifier one?
You hold up a teddy bear. Okay. How many times have kids vomited in your chair? No, it's a serious question. And if it's a teddy bear, that thing is gone.
Yeah.
Okay. This is a practical issue for clinicians. I started this way back when Eager first offered it, and we had these horrifying old, stiff, nasty back cushions. Okay. But they are perfect fit under a kid's legs. When I first started my practice, my original office was a place called the Center on Deafness. And the reason I got so much experience to start with was because I was asked to work with all the students in the deaf school. No beeps. No beeps. What do you do? I bought giant speakers and I put them on either side of the chair, and they put their hands on the speakers and they felt the beeps. Cool. So the tactile feedback, I got to tell you, I don't restrict its use just to the kids.
Cool.
The adults like it too.
Sure. There's a question about the tactile. It says, do you think the tactile feedback works better than audio neurofeedback for younger kids? I guess probably.
Yes.
I don't know.
Well,
as always, it depends.
Okay.
Yeah,
That's
really
an empirical question.
Yeah.
It's a study, does one work better than the other? Well,
oh my God.
It's time for some grad student to do a study, As far as the total number of sessions, the 40 sessions for a simple ADD was kind of set by the book, The 20-Hour Solution. And that made people think it's only 20 sessions. I go in for an hour with the psychiatrist or the psychologist or counselor for the neurofeedback, and during that hour, you get about a half hour of feedback. This is not an hour. This is half hour. So it's 40 sessions, not 20. So if you have simple ADD, 30, 40 sessions should get you there. If you have a learning disability added on top, you can add more time. If you have autism spectrum, you can expect to see somewhere in the 40 to 60 range if you don't have the epileptiform spikes. And probably,
depending on the type of
but if you've got
ASD.
spikes, you may end up going over 100 sessions. I have seen people with epileptiform content come out without any problem at all at 42. That's the fastest I've ever seen, but I don't set that the fastest one I've ever seen as the expectation for a parent who's got to kind of budget time and energy and money for treatment. I'm giving them an honest estimate that given autism with epileptiform content, or if you're presenting specifically as epileptic, it's going to take time. You might be lucky and finish quicker, but your expectation is it takes time. The brain has an inherent learning capability, and it takes time to learn. You can't speed up the inherent rate of learning. And the more deviant you are from normal, the more unwrapping you're going to have to do to get back to that center. So,
all right, you talkers, hold on. How's everybody doing on time? I'll stay here all night. I don't care.
I will too. Yeah, to the point of how long does it take to do neurofeedback? How well does your brain learn? We have no idea. Neither do you, prospective client. And what's the rest of your platform look like? Do you eat well? Do you sleep well? Do you drink enough water? Are you out in nature? Do you have supportive social, constructs? There's 100 variables here as to how well any intervention in anything's going to work. How long is psychotherapy going to work if you're living in a battering relationship, and you go in for, to work with your therapist? How long do you think it's going to take you to get out of that? I don't know. You're repeating the drama daily with an abusive partner. It's going to take a lot longer than if you didn't have that partner to resolve that question for you.
Well, I never end up having this conversation with people. It's the first time they come in, we talk about how many sessions, and that's the end of it.
Right.
Particularly with the autism population. Okay. When children, particularly, are making the kinds of improvements that these parents are seeing, we don't talk about how many more sessions do we need to do. I talk about how much longer am I going to have to see you before you're satisfied? I mean, it just doesn't work that way. I never have to have these conversations because these parents don't want to quit doing sessions as long as their child continues to improve.
Yeah, I want to blend that. What John was saying before, also with Joy, what you were saying, and even Jay, in terms of, I think our long-term clients are those on the spectrum, and it's, we get this beautiful movement, and then we hit a plateau, and the parents at this point, of the family, depending on the age of the child as well, you have a choice whether we just push and try and break through that plateau, or we take a pause, wait for another developmental stage to come in and they kick in. But it's a long-term relationship. This whole notion of, how many sessions to cure my child's autism is like, okay, this is a very interesting question. Let's dial back here a little bit. No, I mean,
let's remove the word cure first of all.
Yeah,
that's
you can't catch it. You can't cure it.
Yeah.
I mean, cure is the wrong model.
Coming in with that absolute miscomprehension. The other classification frequently are athletes. We have very, very long relationship with athletes. We are part of their comprehensive training program. Elite executives, they want to stay sharp. I mean, I guess we're talking about the peak performance. So it all really, really depends. But I do not want to see a child a child with quote unquote standard ADHD or behavioral issues for any length of time. I'm overjoyed, when the treatment is shorter, and for whatever reason you pop into the family 10 years later and the kid has no idea who you are. I love that because that means they did not identify with having a problem. So sometimes I adore not being remembered by a little one. That to me is a sign of success.
Everybody take a breath. Hold on. We are so way over
great.
time. And I am here to, I will keep this recording all night.
I just wanted to say one thing. Maury, that was beautiful. Thank you.
Yeah.
John, your eloquence is unmatched.
Oh my God.
Thank you back.
I think the way this could work, and Jay, please, and Dr. Marie, I think we talk about stuff here, and we got to, 8 o'clock Pacific time, we all get together and we do another show, talk about, we have 7 people talking now, and then we have 3 people talking at the next show. Joe, I would love to have you, anybody on the panel to come on and take a breather and talk about what we talked about here. I don't know if that's how it goes forward, but Jay, your thoughts?
8 o'clock, I know, is better for Joy because she's retired.
I was going to say, are we talking in the morning or the night?
Morning.
That's better.
Yeah,
For
Jay,
me,
what
works on
time
all
are you
times.
talking about?
I thought you were talking about 8 p.m.
I can be here for that.
The end of my day basically is a 4 o'clock show to 5 o'clock, and I've got to have time to spend with Renita and family too. So, and I'm retired, so squeezing it in during the day is easier than it is for folks that aren't. In my retirement, I'm still quite busy, but I'm not writing reports anymore. So
Hey, here's a thought. Guys. Is a Saturday show a good idea? Perhaps more people are available on Saturdays to tune in to a live show. I don't know.
Yeah, maybe.
We're kind of in a,
maybe we
4
tested
o'clock
or something.
drive time, thing. They're in their car probably.
I don't even answer most emails on the weekend.
Well, unlike Joy, I am still working for a living, so I work on Saturdays. No, I'm kidding. Joy, I'm playing with you. You know that.
Well, don't laugh. I don't mind disclosing. I'm literally of an age now where I like working Saturday, Sunday, and I work Saturday, Sunday because everything I want to do, there are too many people out on Saturday, Sunday. So I go skiing on Monday and Tuesdays, not Saturday and Sunday. So yeah.
Well, for the entire panel and everybody that's listening and watching, the way this is working, this is the second time we've done this, and we are like, an hour and a half? Oh God, almost 2 hours doing this.
No.
Yeah.
No, an hour and 23. Come on, don't kill me here.
Hour 46. Joy started it all. And I think it's
Did she show up that early?
When I jumped in on the normal time, and you already had 23 minutes online. So
my God.
Still a live thing.
No, the point is we're here to help spread the word. Okay. I'm letting everybody know what the limitations are of what we're trying to do with this format. And if somebody wants to join tomorrow, I don't think anybody's going to say, no, you can't show up. If we talk about stuff here, we want to continue tomorrow. I don't know, Jay. I don't know, Dr. Marie.
I think you've got lots of people, and as long as you've got a lot of people, you could end up having more than one time slot. People can swap in and out, mix and match, we've got our classic time for the NeuroNoodle podcast, but pick other times and invite other folks. I mean,
just so everybody knows, the classic time, Jay, is 8 o'clock Pacific Standard Time.
AM.
Yeah.
Yes, AM. Right. That's Canadian time, right, Dr. Marie?
Yep.
And just so anybody listening, that's not live.
Right.
Right? You guys aren't doing that live, all right?
We weren't.
Well, we're not doing that much editing anymore because there's not much to edit.
Yeah. Well, I don't know. We talk, one of the comments now is lunch and learn. I mean, I kind of talked about, like how do you match up all the time zones? So there's the after work, which doesn't work for Jay, and Jay is our shining sun. So I would say either early pre-work or noon. You know,
life is all about feedback. We need more feedback. Second show we've done this. Joy, welcome addition.
Thank you.
Anthony coming in. Look at you working the comments. Awesome. Let's record this, throw it up as soon as we're done, and we'll make a less mess next week. What do you think?
Sounds good.
One suggestion that I have.
Go, Joy.
I mentioned this to Pete. As I had mentioned, I unfortunately stuck my hand up and volunteered to work on Reddit.
Yeah.
What an interesting place. Well, but that being said, I would say that taking a slightly removed view of this thing, it's probably one of the best places to find the questions that the public has. Before we gathered today, I sat down and made a list of about 10 of the things that have come up in discussion over the last couple of weeks. Would there be any interest in addressing questions specifically about, like, how do we do it? How many sessions? I mean,
hell yes.
Do that.
If
That's
we
a
address
show right
the
there.
questions.
Joy, I'll give you the link. Anthony, I'll give you the link. John, you'll all get the link. You post it whatever the hell you want. People will come in, and then I'll need your help to sift through the questions.
It could be a Reddit live chat.
Yeah.
You know, you put on the top of the Reddit group, join us if you have a question. I don't know.
Exactly.
Yeah,
No, exactly.
I don't know either.
Andrew Hill put his up there.
Right.
Genius.
Right.
Hey, AJ, this is pretty exciting. I like this. Dr. Marie, I'm in.
okay.
And your camera's working very splendidly tonight.
I give up. I've got a gremlin in my machine here. Yeah, I only went out once tonight.
No, you're
It's got
genius.
that nice wide. It's got that nice wide angle look. I'm liking that.
Yeah, going around in a circle.
So John Mekrut, Anthony
Yes, sir.
Ramos, we'll figure this out going forward. Everybody hey, Joy, you're an amazing woman.
Well, that's
Going
one of the adjectives I've heard.
Yeah.
That's good.
It's on the wanted poster.
The Not Boring Neurofeedback Podcast. I like that.
There you go.
There we go.
Everybody,
Okay.
have a great night. Magnificent content. Thank you all.
It's great to
Thanks,
see
Pete.
all of my friends online. This is a wonderful option. So
Jay, get more
thanks-
friends.
thanks-
You have more friends.
Thanks for people popping in.
All right, guys, take care.
Thanks,
you.
Pete.
Everybody
Have a
have
good
a good
evening.
night.
Bye.